Thank you. So I'm really excited to talk about integrating suicide screening and intervention into the SBIRT model. So I'm Brett Harris. I'm a senior research scientist at Newark University of Chicago, working in the public health research department. I have quite a history in SBIRT. I've been doing SBIRT for, I don't know, like 12 years, I think. And I came to into suicide prevention, and I just really noticed the intersection of the two. And I think that while we know that we want people to be doing SBIRT more, it's actually being done a lot more than suicide prevention is. So we can leverage the SBIRT model to pull in screening and intervention for suicide risk. These are two major issues impacting youth today, that this is the way to do that, to increase screening and intervention for suicide as well as substance use. So we know you're very familiar with the SBIRT model, and we've got different ways to screen, do brief intervention, provide additional sessions of brief intervention, essentially bring youth back for return visits and follow up, and also to provide referrals for treatment or for any other type of service, whether it be less formal service. So with suicide risk, there are multiple screening tools that can be used. We recommend the Columbia Suicide Severity Rating Scale, or the CSSRS, are also referred to as the Columbia. And then we talk about other pre-screens or screens. We know that you are using the PHQ-9. There's also the PHQ-3, which takes the first two questions and the last question, can act as a pre-screen for the Columbia. And then there's a safety planning intervention. So very similar to our BI and SBIRT, this is a brief intervention for suicide risk that would be done right after the screening collaboratively with the trained professional. The extended sessions of brief intervention also are often done in the suicide prevention field, kind of, I guess, you could say by phone. Now that we have new technology, it's not always by phone, but structured phone follow-up. So essentially, the safety planning intervention and the structured follow-up are together evidence-based practices. And then, of course, there are referrals to mental health treatment and other services as well. So that last question that I was talking about from the PHQ-9 and the PHQ-3 can be used as a pre-screen. I'm sure you're all familiar with that question as you use this tool already, but essentially thoughts that you would be better off dead or hurting yourself in some way. So clearly, someone says that they've done this, they've had these feelings over the last number of days, or pretty much any time, that would trigger asking a more detailed suicide risk screening tool. Because what would you do basically if someone said that yes, they've had these thoughts with this simple question? You really don't know enough information. You need to gather more. I also put the ask screening, suicide screening questions. That's another tool. It's usually done for younger kids, like young adolescents, but the Columbia Suicide Severity Rating Scale is done with adolescents and adults. So this is the Columbia screen here. And you can see that you have a question, number one, have you wished you were dead or wished you could go to sleep and not wake up? So that's pretty similar to the question from the PHQ-9. It's indicating passive ideation. And then there's, have you actually had any thoughts about killing yourself? So this is active suicidal ideation. So these are two different questions that get at two different things. If someone says yes to those two questions, you would then go on to ask the rest of the tool. If they say no, you go to question 6 because they want to know about actual behavior. So this is a really critical question. For people that would answer no to question 2. So question 1, as I was saying, that passive ideation is low risk. So you wouldn't continue. So that's so question 2, the active ideation is a little bit riskier. So you can see the level of risk increasing. But both of those are low risk. You can see kind of the category being yellow. That's a low risk. The orange is like a medium risk, a moderate risk, and the red is high risk. So going on through the rest of the tool, I'm sorry, like I think that it looks like the wording just got pushed to the next slide, but that's it says method there, so it's indicating method. Have you thought about how you might do this? So if someone has a method, you can see how that's a little bit higher risk than just having thoughts about suicide. And then question 4, have you had any intention of acting on these thoughts of killing yourself, as opposed to you have the thoughts, but you definitely would not act on them. So that's intent. And then have you started to work out or work out the details of how to kill yourself? Do you intend to carry out this plan? So you have the plan plus the intent. So you can see how each question, there's a different, it's assessing something different, and there's a different level of risk. So like with the SBIRT tool, the screening tools, you can actually tell, it gives you enough information to know what level of intervention to provide based on the responses to the screening questions. And then you're at the next question 6, like we mentioned before, have you done anything, started to do anything, or prepared to do anything to end your life? So this is the actual suicidal behavior. You can see below there, they provide some examples of what's meant by that. That is very high risk. And you can ask, there's lifetime versus recent. So when this is done kind of lifetime, but not within the past 3 months, it's less risky than it is if it's been done recently. So just, I know with SBIRT screening tools, we always talk about a score and what to do with the score. Essentially, depending on the population and the way that your organization wants to handle it, a yes to 3 and below can be positive, or a yes to 4 and below. So when you're taking more of a public health approach and you've got like a population-based approach to this, so like school-based health centers, I would recommend having 3, 4, 5, and 6 be positive rather than just 4, 5, and 6. So how do we interpret this? Having the passive and the active thoughts only would just be a behavioral health referral, particularly in school-based health centers. If you have a behavioral health provider in-house, just kind of referring the student there. Question 3, the suicidal thoughts with the method, but not with a specific plan or intent. It's a little, it's a moderate risk, so a behavioral health consult. And then suicidal intent without a specific plan. So that's the consult as well as patient safety precautions. Same with question 5, when there's the intent with the plan. And then suicidal behavior not within the past 3 months, that's less risky. So that's the consult when considering patient safety precautions. And then there's within the last 3 months, and that's the consultation and the safety precautions. The safety planning intervention, that's the brief intervention I discussed, and we talk about safety plans. This is different than that. So a safety plan, it's not just like a piece of paper that has a couple things written down, and it's not a general plan. This is specifically for when a suicidal crisis emerges. So this is, specifically for the time-limited crisis. So you can say that, so you can't, like when you introduce this, you have to explain how and why it works. So basically, it's to build self-efficacy really for handling suicidal urges within the community on one's own, because these things do come and go, and they can continue for a while, just kind of cyclically. And instead of hospitalizing someone, if you do that, like they could definitely be resistant to mentioning that they have these issues or these thoughts again, and don't get the help that they need. So we want to make sure they're open and honest about these, and that this safety plan is something that will work with them. And we don't want to have an overly general crisis plan, because the triggers and the responses could be different. So if you have a safety plan, say for domestic violence or for substance use or aggression, it wouldn't be the same for when suicidal thoughts come up. So this, as I said, suicide fluctuates over time, and we need to come up with a plan for managing these feelings and staying safe. So it provides a simple format, and it's supposed to be easy to use when the crisis emerges, because you kind of, you go into a panic and you don't always have all of your kind of thought processes formed. So this is just like a simple set of steps. So to come up with the plan, you need to, you would work with the patient, with the student. The clinician guides that and uses, kind of draws in the family, especially when youth are involved in generating their own ideas. So like with the SBIRT intervention, with the like brief negotiated interview and motivational interview, it uses similar skills so that the patient as well as the family are directing this, while the trained provider is really guiding the intervention and coming up, like putting the plan together. So the safety planning intervention has 6 steps, and they go like in progressive order here. So you recognize, it's recognizing warning signs. Each person may have different warning signs. And second is employing internal coping strategies. So that means without contacting someone else. It could be like going for a walk, listening to music. The third step is socializing with others as a way of distraction. So it could be getting together with a friend, just talking about anything, and you're not contacting someone because you're having these thoughts and you want to get help. That step is number 4. So you would contact family or friends to help resolve the crisis. Step 5 is contacting mental health professionals or agencies. And 6 is reducing access to lethal means. So each step would be, so you would, let's say, to use so you would work with the person to come up with the plan. But then if they're using the plan, they would recognize those warning signs. They would have that plan on them. Okay, these are my warning signs. I'm feeling that. Okay, there's something going on here. So I'm going to, go for a walk. That's my internal coping strategy. If that works, that's great. If it doesn't, you go to that next step, and I'm going to call my friend. We're going to, watch the football game or something. Hopefully that is a distraction and it works. If it does not, you would go to the next step. And, I would call, say, my brother, and I have this issue and I need to get help. Can you help me? That doesn't work. Then you have these numbers written down, or ways to contact professionals. It could be your primary care provider or a mental health professional. It can be the crisis text line, the suicide prevention lifeline, or any local hotlines, having those numbers available to call. And then 6, okay, if I, for example, have prescription pills, or I'm a gun owner, I need to temporarily give these away. So I'll go to my brother and say, can you hold these pills for me now? Or, take my gun, store it safely from me. So that's kind of how that plan would work. So it's on the provider to develop the plan. So you would work through, and I just provided a few examples here on the slide of how you would do that. So if you wanted to go through develop step 1, you could ask the patient, what do you experience when you start to think about suicide or feel extremely depressed? How will you know when the safety plan should be used? So then you can start listing the warning signs using the patient's own words. And then you would go into internal coping strategies, like what can you do on your own if you become suicidal again to resist acting on your thoughts or urges. And again, you want to keep checking in. How likely is it that you use this in a time of crisis? Because they can give you different ideas and thoughts and options that they would actually rarely or never use. So you want to make sure it's something when that time comes up that they will use. If they express doubt, what might prevent you from doing these activities? Social contacts may distract from the crisis. So who may help you take your mind off the problems, at least for a little while? Who helps you feel better when you talk with them? And then for those who may offer help, so among your family or friends, who do you think you could contact for help during the crisis? Or who do you feel you can talk with when you're under stress? For the professional agencies to contact, who are the mental health professionals that we should identify to be on your safety plan? Are there other health providers? And then again, you can list other names, numbers, like I talked about a minute ago. And then making the environment safe. So do you own a firearm, which is a gun or a rifle? I think, talking about youth, do your family own one? Do you have one in the house? What other means you have, that you could use to attempt to kill yourself? And how can we go about developing a plan to limit your access to these means? So what do you do with this information? So maybe, a while ago you give them a piece of paper to carry with them, but now, of course, we have apps for everything. So this, I know looks like it got cut off a little bit, but it's the My3 app. You can see it like in the picture on the phone. And this is a very well-used app, particularly among adolescents, and it has the entire safety plan on there. So if the safety plan, and a lot of times providers will have the youth enter the safety plan on their phones while they're still there at the appointment. And then, kids always have phones on them, adults do too. So if a crisis does emerge, they have that safety plan, they can go through and access it from their phones. Now, the follow-up and monitoring, the structured phone follow-up, which I mentioned. So there's strong evidence about the impact of the safety planning intervention followed by the structured phone follow-up, both with adolescents and adults. So these are all evidence-based practices. So this would happen 24 to 48 hours after the initial contact. That provides support during a time of elevated risk. So you want to assess mood and current risk. So you could administer the Columbia screen again to see the level of risk, and then if there's imminent risk, to contact the crisis line. And one of the really important steps here is to review and revise the safety plan. So at this point, they may have had time to give some thought to that plan. And so these calls, it's not just one time, they recur a bit. So after a while, having them reviewing and revising the safety plan is important. So maybe there are some things that weren't helpful or they didn't use, and then identify more helpful ones. What about access to means, and is there a need to remove them? What's really important, I think we all know, is treatment, engagement, and motivation. So what is the treatment plan option, to review that, and then to problem solve obstacles to treatment. And then again, information about community sports, lifeline, crisis text line. So I can't stress that enough, to make sure that youth, adults, whomever the patients are, have access to these numbers and are continually reminded about them. Even if a patient screens negative on the Columbia screen, that there's no risk, just providing these numbers. We know that, particularly now with COVID, it's a difficult time, that things come up. And so, for example, like the crisis text line is not just for suicide risk, it's for substance misuse, it's for domestic violence, it's for relationship problems, anxiety, depression. So it's a very useful number, and people like to text now. So very easy to use. And then, of course, obtain consent and make sure that they're willing for additional follow-up calls. So it's important to set the call time as well, and let them know how they can contact you in between calls if they need to. So one of the last things the last thing I wanted to mention, which is also evidence-based and very easy to implement, are non-demand caring contacts. These are simple expressions of caring. The initial study from 2001, which is strong evidence of impact, was done via postcards, but it can be done letters, emails, and now texts. And so you could see the result here from the study. And then seeing the picture on the phone, I mean, simply, it's just like, it's been some time since you were here, and we hope things are going well for you. If you wish to drop us a note, we would be glad to hear from you. So it's just nice and personal, so people know that someone's thinking about them. And then, of course, the warm handoff to other levels of care and for treatment. So there are a few suicide-specific treatments which are evidence-based. There's a cognitive behavioral therapy specifically for suicide prevention. There's dialectical behavioral therapy, or DBT. And then there's collaborative assessment and management of suicidality, or CAMS. All right, so that's all I have, and I want to thank you for your time, and my email address is here if you want to contact me. And I'm not sure